So we are back, and we're so excited to be here with Dr. Mark Sender, a well-renowned urologist, local urologist, and we were talking, Dr. Sender, about ED medications, and I have had patients in my office who say, well, I just ordered something on the internet and it's not working real well. And how do you do that? I think it's probably, I don't want to say, I was going to say more millennials, but it could be baby boomers. Everybody loves the internet and thinks that's the answer to everything. So could you talk a little bit about that?
Sure, I'd be happy to, although I have to admit I am no expert on buying drugs over the internet. I actually don't advocate it. The drugs for erection that one can buy over the internet may be ethical or may not be. It's a crapshoot. I've certainly had patients come to see me because they have erection problems, and they say, well, I got something from Canada and it worked fine. And I said, well, that's great. So why are you seeing me? But by the same token, there are other folks who come and say, well, I've tried the medicines and it doesn't work. And I don't know whether it's because the medicine doesn't work or because they have a medicine that isn't really a medicine. So how does this stuff work? There's basically a particular kind of drug that was recognized to be able to induce an erection. I'm not going to go into the complete physiology involved, but every one of the drugs that one's heard of before is in a category called a phosphodiesterase inhibitor, type 5. And that's the Cialises, the Viagras, the Levitras, the Staxins, the Stendras. There's all kinds of drugs out there. They basically all do the same thing, but because of their structures, they may last a different amount of time. But they're still doing the same thing. And the thing they're trying to do is to increase the blood flow to the penis, and the hydraulic nature of the cylinder inside the penis that fills with blood, if it fills adequately and the blood doesn't drain out too fast, an appropriate erection occurs. And the causes of that are myriad. I mean, there may be the psychological ones, there may be the physical ones, there can be related to medications that the patient may be taking. It can be post-surgical in some cases. There are many, many reasons, and this is a reason why someone should see a urologist. You had asked me earlier, why would someone come in to see a urologist? Right. Erection problems is an obvious one. And in defense of the drugs, they really work. They work quite well. If they don't work quite well, we have fallback ways of dealing with the erection problems. And the most common one is to do a test in which one injects medicine directly into the penis. In fact, that's a business model by a group out of Boston that does that for everybody, although it's, in my sense, it's not the most ethical way of dealing with erection problems, because there are other ways of doing it that are far less expensive, and that's my 2 cents on that. But it sometimes is appropriate to directly put the medicine directly into the penis, and that's done by injection. Should that not work, that's typically not a psychological problem, that's a physical problem, and that deserves further workup. And it may be that the solution has to be something either surgical or mechanical. And I know that this is a radio program that typically doesn't have a lot of young kids, but I won't go into details right now. Just say.
Sometimes when I talk to patients about the medicine, I try to explain them in such a lay way of saying, I say what happens with this medicine is that it closes down the valves so the blood cannot get out of the penis, but it continues to go down, and so it causes engorgement, and that's how it works. And I think patients understand that more than the phosphodiesterase inhibitor.
Oh, yeah.
Phosphodiesterase inhibitor. That's a little bit harder for some of our listeners.
I can't even say it or spell it.
Okay, that may be so, but It's actually a little more sophisticated than what you've described, but essentially that's what happens. By increasing the blood flow into the penis, it allows the blood vessels to engorge, and the engorged blood vessels put pressure on the fibrous cylinder that surrounds this blood-filled part of the penis, and the pressure of the blood on the fibrous walls collapses those blood vessels, so blood can't flow out, at least not as fast as the patient would be fearful that it would. And so that's the hydraulic and the natural aspect of it. But the important thing is that we have ways of treating this problem that can be very successful, and this is really a psychological problem in many cases that can be overcome by cajoling the patient into trying a medication or understanding what the physiology is. And many times, understanding that there is that kind of issue going on, it can be overcome. Although not in all cases, and that's why, Judith, you're around.
Thank you. And I have to tell you, if someone comes to me with erectile problems, I always ask them if they have seen their doctor first. And if everything checks out, then we go into the psychological. What's stressing you? What are the underlying messages? What is really going on? Because if something psychologically is going on, many times not even the magic pills are going to work for you. So my only concern, I know we want to get to some other issues, but my concern too is that, do you think there are too many healthy younger men who are taking these kind of as a Band-Aid or something because it's there, and is that healthy or not healthy? I think it's kind of like, well, I'm just going to use this as a sure thing and I don't have to.
Well, I think some of the patients I see that are younger that probably technically don't need the medicine, they just want a backup. They want to make sure that everything's perfect, the best they can be, and
right.
Because they have a special event. So
I love it. I hope they have a special event. That's wonderful.
I agree with Greg. That certainly happens. So except for the fact that someone can have a side effect to the drug, the main concern is that there's also an expense to the drug that certainly is not negligible. You understand that some of these pills are like $20 a pill.
No, they're up to $50
okay,
a pill. Okay,
$50 a pill. I guess I'm not paying enough attention. And being that expensive, that can really put a strain on someone's relationship if it's not working. That's another stress. To give you an idea, you understand, anybody who's watched television in the evening over the last almost decade has encountered a Viagra commercial or a Cialis commercial, at the end of which they talk about, if you have an erection lasting for more than 4 hours, go see your doctor, blah, blah, blah. Well, the fact of the matter is that is not just good advice, that's absolutely essential. But should that happen to a patient, what we do is we're able to reduce the erection if it hasn't happened many hours before, 8 hours, 10 hours, 12 hours or whatnot. And we do it by injecting medication directly into the penis, and that medication is epinephrine or adrenaline. Adrenaline is what is put out by your adrenal glands as the flight or fright hormone. In other words, if you hear a gunshot, you may go running because your adrenaline just packed in there and you ran fast and furious away from it. There are many examples of flight and fright. But the point is that if someone has a delicate balance between their ability to achieve an erection and not, it may have something to do with their level of that hormone in the system. And being anxious, the adrenal glands do put out more adrenaline than you probably want. So the first thing to do is to say, just relax. It'll probably be okay. Which, of course, is impossible. That's like telling someone, I don't want you to think about a pink elephant. What are you going to do?
Right.
First thing.
Sometimes I when I give these medicines to patients, and by the way, we're not sponsored by Viagra or Cialis or Levitra, but those are the names
Well,
of the
maybe
drugs.
we could get them to sponsor
Maybe, you're
us.
right,
That would
yeah.
be great.
But sometimes I tell them, put their hands on the phone and 3 hours and 59 minutes. Call me if nothing's happening. If something's not working right, call me right away so we can get this reversed. I've never been called, by the way.
Well, I have mentioned to some younger men, all they think about is the erection, and I try to get them to think about pleasing their partner and with foreplay. And last week I said to a young man, a woman needs at least 20 minutes minimum. And he looked at me like I was absolutely insane. I said, no, I want you to repeat after me 20 minutes. And sometimes that can bring some of the anxiety down. And it's about pleasing the partner, not how they think pleasing the partner may be. But, I hope we don't take these drugs recreationally. A backup is fine, not a problem, but just because when you're young and it's not the problem. It's not a physical problem. So we wanted to move on while we have Dr. Sender captive and to talk a little bit about prostate cancer.
Okay, I appreciate that we can move on from the sublime. So, prostate cancer is a very prevalent cancer in throughout the world, but in the United States, it's literally the second leading cause of cancer death, and the second leading cancer that is in that's diagnosed. It's about 1 in 7 men can be expected to get prostate cancer at some time in their life. And that's sort of a daunting number. And with that in mind, the question is, what do you do about it? Well, the good news is, many times you don't have to do anything about it. It turns out that men in their 80s, probably half of them have prostate cancer. But of course, half of the men in their 80s don't die of prostate cancer. They die with prostate cancer. And younger men have prostate cancer and don't die of it and aren't destined to die of it. And the distinction is, and the role of the urologist is, to identify those patients who might die needlessly of prostate cancer. There are about 26,000 deaths by prostate cancer yearly, and it used to be far, far more than that when approximately 27, 28 years ago, there was a discovery of a protein in the bloodstream called PSA, which was related to the prostate. And if I might digress for just a second, I was actually in the lab at UC Berkeley in the School of Criminology doing biochemical research, and we found a protein that hadn't previously been identified. And it turns out that that is the protein that ultimately was defined and designated as this prostate-specific antigen. And the question was, well, you're in the School of Criminology. What do you care about the prostate and whatnot? Well, it was 1972, 73, and it was a test that didn't have any reason for being, because people didn't know how to essentially monetize the discovery. We had initially gone in with the notion that we could find some protein in the blood that we could be able to use to identify patients, much as we use DNA now, because back in 1972 we didn't have any ability to, designate or to do any gene testing or DNA testing. So it was more of a Dick Tracy kind of thing way back then. The point being that eventually the PSA was found to be a useful tool for identifying the fact that a prostate was present, that the prostate the prostate levels may be abnormal, and that abnormal levels are often associated with cancer. And it's been used for that for these many years, but it's not a test for cancer. It's simply a test to say there's something going on with the prostate and we need to investigate it. So having said that, there's been a huge overuse of this test, PSA. The recommendations now are that it not even be performed. There's a large consortium of physicians who look at whether tests are appropriate or not, and their recommendation was not to look at PSA, but just simply evaluate men by a digital rectal exam, and if there may be a suspicion that there's something going wrong on that exam, perhaps then get a PSA test. The problem there, of course, is that before we had this PSA test, people were dying of prostate cancer in tremendous numbers. Approximately 28% of the people who were diagnosed were dying of prostate cancer. Now it's less than 1% with the use of PSA, so that's a tremendous improvement. But we found, since the recommendations came about not to do PSA, little by little, more and more people are discovered to have prostate cancer that we otherwise would have diagnosed earlier, and it may be too late, and they are indeed dying needlessly of prostate cancer. So the rates of death from the disease is going up, and that's unfortunate. So there's been a tension and a conflict by some of the urologists who do well, not some urologists, but urologists who do perform the PSA test and do treat people for prostate cancer were kind of outraged by the notion that this test, which was such a boon to so many patients, was going to be abandoned. And, there's a lot more that can be said about that, but the recommendations by many cancer groups are still to get a PSA between 40 and 45, and if it's a very low number, less than 1, not to get another one until they're 50. If it's above 1, to get one every 2 years, and then at age 50, get one every 2 years to see what happens in the trend of PSA, because that can be related to prostate cancer, which, as I said, is a very prevalent disease.
Well, I when I see patients in the office and they ask about getting a PSA, I said, well, one of the best tests really is the digital exam, because you can really feel it. I tell them what it should feel like and what it does feel like and how big it is. But most men don't like that test, and so we end up doing both most of the time because they want to get the PSA to validate, and I want to do the digital exam because I know it's thorough.
You're absolutely right. Those tests work in harmony. They both need to be done. But suffice it to say, you have to give credence to the large consortium of doctors who made the decision that they didn't think prostate cancer testing by PSA is a test that should be performed. However, whenever a test is done, the doctor should talk with the patient about what the pros and cons are, what the benefits are, what the risks are, and what the goal of understanding what the result of that test is. That's to say, if one were to see a patient, the patient had an elevated PSA, that would drive a biopsy to find out if the PSA, or rather if the prostate has prostate cancer, and that leads to other things such as the various kinds of treatments, all of which have significant and potentially risky effects, which we can go into after.
I'd like to say before we go to break again is that unfortunately the insurance companies determine what kind of test you have done. For women, mammograms, the radiologist thinks you should have it done every year, American Cancer every year. The federal government says every 2 years. So then the insurance companies will say, okay, well, the government says it's 2 years, so you only get a mammogram every 2 years. Same thing with these PSA tests. They say, well, you're not going to get that many, even though patient clearly needs it. So sometimes the patients get stuck in the middle of the bureaucratic part of medicine.
Well, I do want to talk about, after we go to break, I want to talk about the treatment for let's say, a happily married man who is in a sexual relationship at age 48 is diagnosed with prostate cancer. What is the treatment of choice?
So we're going to wrap it up right now. We'll be right back. This is the Doc and Doc Show, AM 1220, KHTS. Our phone number is 298-5487. Please give us a call. Thank you.
And it's the Doc and Doc Show, and we are back with Dr. Mark Sender. I don't want to say anything else. I want to go right to Dr. Sender, and let's continue talking about prostate cancer.
Yes, you asked the question, Judith, about how someone with prostate cancer might be treated, and you're talking about a 48-year-old. So prostate cancer is not just one disease, and I kind of alluded to it early on. Not everybody with prostate cancer needs to be treated. I think a 48-year-old needs to be treated because his timeline, his horizon is maybe another 40 to 50 years nowadays. And you can't really expect cancer to be indolent for that long a time. So probably a person like that should be treated. If you were to say someone was like 68, 72, we usually do a cutoff at about 73 because actuarial tables suggest that it doesn't make a lot of sense to perhaps operate on someone that beyond that age. But be that as it may, a younger person probably should have some definitive therapy. And definitive therapy means either surgery, that's called a radical prostatectomy, and radical prostatectomies are now most often done with the aid of the Da Vinci robot. For instance, my associate, Dr. Stepanian, he's fellowship trained to do that, and that's what he does. He just takes the prostate out and the patients go home the next day. When I used to do them open, patients would be in the hospital usually about 3 days, but the success rate in terms of rendering someone cancer-free is highly, highly successful with that. So the 48-year-old would either be surgery, probably robotic-assisted surgery, or some sort of radiation therapy. Radiation therapy can cure prostate cancer, just like surgery removing the gland with all the cancer in it can also cure the patient of prostate cancer. There are other treatments available. There are treatments if the disease is no longer confined to the prostate. If the prostate cancer is no longer simply in the prostate, treating the prostate alone is not going to cure the patient. And the goal of treatment, particularly in someone as young as a 48-year-old, would be to cure the patient. As I suggested, there's prostate cancer is a range of disease in the sense that when you look at it under the microscope, it doesn't look like just one kind of thing. It has a gradation. Some looks more like normal prostate cancer, other stuff looks worse and less like normal tissue. And the more aggressive appearing diseases tend to be those that you need to really treat aggressively. Some you don't need to treat, and what we do is called active surveillance. We watch the patient to see if they fall out from some kind of thing whereby they can't be watched anymore.
Thank you. One thing, I hope you come back and visit us, Dr. Sender, because you've given us so much great information. So I think we really appreciate you taking time out of your day to come and see us. And we also wanted to be in solidarity and in spirit with the people who have suffered from the Orlando shootings. That's been on everyone's mind, and we wanted to be that way. So with love, we are Dr. Gregory Jenkins, and I'm Dr. Judith Curts, and you are listening to AM 1220 KHTS.
Have you been putting off those home repairs?